Good afternoon, everyone. My name is Courtney Henderson, and today I will be presenting my paper entitled Erectile Disorder, Individual, Relational, and Clinical Implications for Couples Counseling. When many people hear the word erectile disorder, they immediately think about a medical problem or sexual performance. While that is certainly part of the discussion, my research showed that the effects often extend much further than the physical symptom itself. Erectile disorder can affect how a man views himself and how he relates with his spouse and how a couple communicates during one of the most vulnerable areas of marriage. It can also create shame, misunderstanding, and emotional distance in itself if it's not addressed appropriately. As a future counselor, uh, we're in a unique position because we don't simply focus on symptoms. We seek to understand the person, the relationship, and the meaning that both partners attach to the problem. Today, I'll discuss how erectile disorder affects individuals, how it impacts couples, and how the counselor can respond through thoughtful assessment, accurate diagnosis, and ethical practice and evidence-based treatment. Here is a brief overview of today's presentation. I'll begin introducing erectile disorder and explaining why it matters in the counseling setting. I'll also review the basic diagnosis criteria from the DSM 5-TR and discuss the emotional experience many clients face. Next, we'll shift our attention to the relationship itself. I'll introduce a composite case involving John and Sarah to illustrate how erectile disorder often affects both spouses, and though only one person receives the diagnosis. Finally, we'll look at the counselor's role through assessment, systemic intervention, ethical considerations, and several practical takeaways that emerge from the research. As you'll notice throughout the presentation, one consistent theme is that while erectile disorder is diagnosed from an individual, it affects or experienced by the couple as a whole. I will also Before discussing diagnosis treatment, I think it's important to ask a simple question. Why does this topic matter to counselors? One of the strongest themes throughout this research is erectile disorder is rarely just about sexual performance. For many men, it touches a deeper issue like confidence, identity, self-worth, and fear of failure. When it happens, many men begin withdrawing emotionally and physically, not because they no longer love their spouse, but because they're trying to avoid another painful, embarrassing experience. That difficulty is that the partner usually does not know what's happening internally. Instead, withdrawal may be interpreted as rejection, a loss of attraction, and even infidelity. In the absence of communication, both spouses begin creating explanations that often are inaccurate. As counselors, we have to resist the temptation to immediately solve the problem. Instead, we first create space to understand each person's experience. Our goal is to replace assumptions with understanding, reduce shame, and help the couple begin seeing the problem as something they can face together rather than something that separates them. The counselor's stance of empathy, curiosity, and accuracy becomes the foundation for everything that follows. This slide focuses on the human side of the diagnosis. One of the things that stood out to me during my research is that no two men experience erectile disorder in exactly the same way. Their response is shaped by factors like age, physical health, culture, religious beliefs, relationship quality, previous experiences, and even personal beliefs about masculinity. Many men begin anticipating failure before intimacy even begins. Instead of simply enjoying closeness with their spouse, they begin monitoring their bodies and wondering whether they'll be able to perform. That anxiety often creates even more pressure, making the problem worse. The research also found that many men experience reduced confidence, lower self esteem, sadness, irritability, and even symptoms of depression. Some began avoiding altogether because they fear affection might eventually lead to sexual expectation they don't believe they can meet. From the outside, that behavior may appear cold or disinterested. From the inside, it's often an attempt to protect themselves from embarrassment or even painful experience. That's why counselors need to move beyond symptoms and ask deeper questions, such as what does the problem mean to this individual? When we understand the meaning behind the symptom, we can begin understanding the client. Up to this point, we focus primarily on the individual's experience with erectile disorder. We've looked at the diagnosis and considered the emotional impact it can have on the man experiencing symptoms. Now, I'd like to shift our attention to something equally important: the relationship itself. One of the major themes throughout the research is that erectile disorder rarely affects only one person. While only one partner may receive the diagnosis, both spouses often experience emotional and relational consequences. To illustrate that, I'll first describe a common relationship pattern that develops in many couples. And then I'll introduce a composite case involving John and Sarah that brings those concepts together. One of the things I found most interesting during my research is that couples often become trapped in a cycle that neither spouse intends to create. Imagine what happens. The husband experiences erectile difficulty. That's what he experiences. Naturally, he feels embarrassed and begins worrying that it will happen again. Instead of risking another disappointing experience, he begins avoiding intimacy altogether. From his perspective, withdrawal feels safer than failure. But his wife doesn't know what's happening internally. She notices the distance, but has no explanation for it. As a result, she naturally begins asking herself questions. Has he lost interest in me? Is he attracted to me? Is something wrong in our marriage? The more uncertain she becomes, the more she seeks reassurance. Unfortunately, those questions often increase her husband's sense of pleasure. Now he feels like he is being evaluated every time intimacy comes up. So he withdraws even further. At this point, both spouses are hurting. He's trying to avoid shame. She's trying to avoid rejection. Neither person is trying to hurt the other, yet their attempts to protect themselves keep pushing them further apart. One thing I appreciate about a systemic counseling approach is that it helps us see the cycle as the problem, not either spouse. Once the couple recognize the pattern, they can begin working together against the cycle instead of working against each other. John and Sarah are a composite case that I developed from research. They've been married for 15 years and came to counseling because they were arguing more frequently. They'd grown emotionally distant. Their sexual relationship had become increasingly strained. Initially, John never mentioned erectile difficulties. Instead, he talked about feeling criticized and unappreciated. The assessment continued. However, he disclosed that he'd been experiencing erectile difficulty for about 8 months. At first, the problem only happened occasionally after long, stressful days. Eventually, it became more consistent. Rather than risking another disappointing experience, John simply stopped initiating intimacy. Sarah interpreted those changes very differently. Without knowing what John was experiencing, she concluded he no longer desired her or that something in the relationship had changed. She wasn't trying to accuse him, she was trying to understand what was happening. John, however, heard criticism. The result was exactly what we discussed on the previous slide. Both spouses were responding to the same situation, but they were interpreting it through completely different lenses. I think that's one of the biggest lessons counselors can learn from this case. Many relationships, conflicts aren't caused by bad intentions. They are caused by inaccurate interpretations. Now that we've seen how erectile disorder can affect both partners, the next question becomes, how should a counselor respond? The final section focuses on the practical side of counseling. We'll look at assessment, diagnosis, treatment planning, and counseling approaches that are supported by the research throughout this process. One principle remains consistent. Our goal isn't primarily to reduce symptoms. Our goal is to help individuals and couples understand what's happening, reduce shame, improve communication, and move toward a healthier relationship. One of the most important responsibilities of counselors is conducting a thorough assessment before reaching a conclusion. Erectile disorder is influenced by many different factors, such as assessment should always be comprehensive. I'll begin by asking, when the symptoms first appeared, how often they occur, and whether they happen in every situation or only under certain circumstances. I'll also explore factors like orgasm, pain, stress, anxiety, depression, trauma history, sleep, substance use, pornography use when clinically appropriate, and the overall quality of relationship. Another important part of the assessment is including both partners. John and Sarah were living through the same experience, but they understood them differently. Giving each spouse the opportunity to explain what they've been experiencing often reveals misunderstanding that would otherwise remain hidden. Medical collaboration is also essential because erectile disorder can be associated with cardiovascular disease, diabetes, hormonal concerns, neurological disorders, medication, side effects, and other medical conditions. Counselors should never attempt to replace an appropriate medical evaluation. Instead, our role is to work alongside physicians while addressing the emotional and relational dimensions of the problem. The collaborative approach provides the best care for both individual and couple. After completing a thorough assessment, the next step is determining whether the client's symptoms actually meet the diagnosis criteria for erectile disorder. One point I want to emphasize is that the diagnosis should never be rushed. In John's case, his symptoms had lasted for more than 8 months, occurred during most attempts at sexual activity, and caused significant distress for both him and his marriage. Based on the DSM, erectile disorder appeared to be an appropriate working diagnosis. However, there was still more information that needed to be gathered. John recently started medication for hypertension. He'd gained weight, wasn't sleeping well, and had a family history of heart disease. Any of those factors could contribute to erectile difficulties. That's why I believe a provisional diagnosis is often the most responsible approach until medical evaluation provides additional information. The diagnosis should guide treatment, but it should never define the person. John is not an erectile dysfunction patient. He is a husband experiencing a treatable condition. That distinction matters because labeling can either reduce confusion or increase shame, depending on how they're used. As a counselor, we use diagnosis as clinical tools, not as a description of someone worthy of identity. Ethical practice is especially important when counseling couples about sexual concerns because these conversations involve some of the most private areas of a person's life. One of the first responsibilities is informed consent. Both partners need to understand how confidentiality will be handled, particularly if individual sessions are included along with couple sessions. It is also important to remind and remain within the scope of practice. As counselors, we can assess emotional and relational concerns, but we should never attempt to diagnose medical cause or manage medications. If specialized treatment is needed, consultation or referral demonstrates professionalism rather than weakness. Cultural humility is equally important. Every couple brings different beliefs about sexuality, aging, marriage, privacy, and general roles, and faith. Our role isn't to impose our values. Instead, we help couples pursue healthy goals that are consistent with their own values while remaining grounded in ethical practice. Ultimately, my counseling goals would be to reduce shame, improve communication, strengthen emotional safety, and help the couple experience intimacy without unnecessary pressure. As I conclude, there are three main ideas I'd like you to remember. First, erectile disorder should never be viewed as only a sexual performance problem. It often affects confidence, emotional health, identity, and relationship satisfaction. Second, effective counseling requires an integrated approach. Medical evaluation, psychological treatment, and couples counseling all have valuable roles to play. Addressing only one part of the problem often leaves important issues unresolved. Finally, healing begins when both partners develop a shared understanding of what's happening. When assumptions are replaced by honest communication, shame begins to decrease. And when blame decreases, emotional safety begins to increase. And when emotional safety increases, couples are much better positioned to rebuild both emotional and physical intimacy. For me, that's one of the most encouraging findings of this research. The goal isn't perfection. The goal is helping couples move from isolation towards understanding and from fear towards a greater connection.